Welcome back to the deep dive. Today, we're really getting into some complex territory. We're tackling neurodegenerative disorders.
It's really challenging.
Our mission, is to truly unpack the intricate details. What are these disorders? How do they show up? What do we actually know about the causes?
And the treatments too, right? Both the established ones and what's on the horizon.
Exactly. Our goal for you today, it's ambitious. We want to give you a kind of shortcut, a way to grasp these conditions with the clarity, the insight you'd expect from top professionals in the field.
So you get beyond just the what.
Right, into the why and the how.
And that's exactly what we're aiming for in this deep dive. It's honestly fascinating stuff. The brain's complexity is just staggering. And how these conditions manage to exploit, very specific vulnerabilities within it.
Specific is the key word there, I think.
Absolutely. So our goal is to take all this detailed information, synthesize it, and make it clear, make it actionable for you, help you connect those dots.
So you see the whole picture, not just the pieces.
Precisely. The context is everything here.
The foundation's what defines neurodegenerative disorders.
Okay, let's start there. Unpack that core concept. Neurodegenerative disorders. They're defined by something very specific, right? And pretty devastating.
They really are. At their heart, it's about the progressive and, crucially, irreversible loss of neurons.
Progressive meaning?
Meaning they get worse over time, relentlessly. It's often a slow, insidious decline, but it's always forward.
And irreversible. That sounds final.
It is, unfortunately. Unlike some other cells, neurons, the brain's building blocks, they don't typically regenerate or grow back once they're lost. And what's really striking, a big clue, is that this loss isn't just random. It's not like the whole brain is equally affected.
Ah, right. You mentioned specific vulnerability.
Exactly. The damage happens in very specific, targeted regions. And the selective targeting is what leads to the distinct symptoms we see in each different disorder.
Okay, so let's look at examples like Parkinson's, PD, and Huntington's, HD. What gets hit there?
In both PD and HD, the primary neuronal loss happens deep inside the brain, in structures we call the basal ganglia.
And the basal ganglia are all about?
Movement control, coordinating our actions.
Yeah.
So lose neurons there, and the direct result is major problems with movement control. You see the tremors, the stiffness in PD, or those uncontrolled sort of dance-like movements in HD.
Makes sense. What about Alzheimer's then? AD. Different target.
Totally different target. In Alzheimer's, the main hits are the hippocampus and the cortical neurons, the outer layers of the brain.
Hippocampus. That's memory, right? The big memory center.
Exactly. So the brain's hub for making new memories. So when you lose neurons there, the tragic consequence is profound impairment of memory, of cognitive ability. It really chips away at thinking and recollection.
And ALS, Lou Gehrig's disease, where's the attack focus there?
ALS targets the motor neurons, specifically the ones in the spinal cord, the brainstem, and the cortex that control voluntary movement.
The ones that tell your muscles what to do.
Precisely. So when these degenerate, the result is devastating motor weakness. It affects speaking, swallowing, eventually even breathing. It's a direct assault on the body's physical control system.
So historically treating these, it must have been incredibly tough. You said therapy is mostly just focused on symptoms.
For a very long time, yes. The focus was primarily on alleviating symptoms, making patients more comfortable, maybe improving quality of life for a bit.
But not stopping the actual brain damage.
Exactly. Not stopping it, not reversing it, not even really slowing it down significantly. It was symptom management, pure and simple.
Like you said, bailing water out of leaky boat instead of patching the hole.
That's a perfect analogy, just managing the downstream effects.
Yeah.
But, and this is the exciting part, we are absolutely entering a new era now.
The disease-modifying treatments you mentioned.
Yes, this is a fundamental shift. Instead of just managing symptoms, the goal now is targeting the actual molecules, the root mechanisms, the pathways that drive the disease at a cellular level.
Like going after the cause.
Precisely. A landmark example, even with all the discussion around it, is aducanumab, the first anti-amyloid beta antibody approved for Alzheimer's.
Even with controversies, its approval signals a big change.
It absolutely signals this powerful new direction, moving beyond just symptom relief to tackling the underlying pathology.
It really is like the difference between constantly putting buckets under a leaky roof.
Right.
Versus actually getting up there, finding the structural flaw, and fixing the roof itself. That's the leap we're starting to see.
That's the hope. Tackling the root cause, offering a new kind of hope for these really devastating conditions.
Common threads, unifying features across disorders.
Okay, this is where for me, it gets really interesting. You mentioned these diseases hit different spots, look different, but there's a common thread, something called a proteinopathy.
Yes, proteinopathy. It's a really critical unifying concept here. Basically, it refers to the characteristic accumulation of specific proteins that misfold and clump together, forming toxic aggregates inside or outside brain cells.
Misfolded proteins? Like they're not doing their job properly and start gumming up the works?
That's a great way to put it. Normally, these proteins have specific vital functions. But for reasons we're still figuring out, they go wrong. They misfold, become dysfunctional, stick together.
Like rust jamming a gear in a machine.
Exactly. Interfering with the whole system.
Can you give us the names of these culprits? Which protein goes wrong in which disease?
Sure. So in Parkinson's, the main one is alpha-synuclein. That's what makes up those Lewy bodies you see inside the cells.
Okay, alpha-synuclein for PD Alzheimer's.
Alzheimer's is a bit of a double whammy. You have amyloid beta, or AA, forming plaques outside the cells, and then inside the cells you have the microtubule-associated protein tau forming neurofibrillary tangles.
Two different proteins causing trouble there. And ALS.
In most ALS cases, the culprit is TDP-43, a protein involved in processing RNA.
And Huntington's.
That's the Huntington protein itself. Because of the genetic mutation, it takes on this toxic aggregate-prone form.
So different proteins, same bad habit. Misfolding and clumping up. It's a powerful connection. But you said there are still big unknowns.
Oh, absolutely. The biggest is probably why. Why do these specific proteins start misfolding and accumulating in the first place? It's a huge question. And another critical one is whether it's the big visible clumps, the plaques and tangles we can see, or maybe smaller soluble forms of these proteins that are the real drivers of the damage.
Why does that distinction matter so much?
Because it tells us where to aim our drugs. Do we need treatments that break up the big aggregates? Or should we focus on neutralizing those smaller, maybe more toxic, soluble pieces before they clump up? It completely changes the therapeutic strategy.
Fascinating. Okay, another puzzle you mentioned is this selective vulnerability, how these diseases are so incredibly picky about which neurons they attack.
It's truly striking. It's not a scattergun approach. It's highly targeted. We call it selective vulnerability.
Give us some examples again, like in Parkinson's.
In Parkinson's, you see this devastating loss, specifically of the dopamine-producing neurons in that tiny area, the substantia nigra pars compacta. But other parts of the brain, like the cortex, are relatively spared, especially early on. It's incredibly precise.
Right, hitting just the dopamine factories needed for movement. And Alzheimer's.
In AD, the damage is worst in the hippocampus and neocortex, the memory and thinking centers. But even within the cortex, different networks are affected differently. Again, very selective.
And Huntington's and ALS, same pattern.
Similar principle, different targets. In Huntington's, the weird thing is the faulty gene is active everywhere in the body. But the damage is most prominent in the neostriatum, part of the basal ganglia, and the cortex. For ALS, it's a direct hit on the motor neurons, both the ones in the spinal cord controlling muscles and the ones in the brain sending the signals down. The whole motor command chain is attacked.
So why? Why this precision targeting? What makes certain neurons vulnerable?
It seems to be a complex interaction. It's likely a mix of the intrinsic properties of the neurons themselves. Maybe some are just naturally more susceptible to things like excitotoxic injury, which is damage from too much glutamate stimulation.
Like being overstimulated to death.
Sort of, yes. Or it could be differences in how they handle oxidative metabolism. Generating energy creates damaging byproducts, free radicals. Maybe some neurons are just less equipped to handle that oxidative stress over time. And on top of these intrinsic factors, you have the interplay with genetics and environmental influences. It all comes together to determine who gets hit where.
Which leads to that huge question. If we figure out why some neurons are vulnerable, could we protect them before the damage starts?
That's the holy grail of neuroprotection, absolutely.
So bringing it all together, cause.
Yeah.
Is it mostly genes or the environment? How does that balance work?
It's definitely a complex dance. All these major disorders can be inherited, but how common that is varies a lot.
Like Huntington's, you said that's almost purely genetic.
Exactly. Huntington's is unique. It's autosomal dominant. Get one copy of that faulty gene with the expanded repeat and you will get the disease. It's close to 100% certainty. But even then, environmental factors can still influence when symptoms start and how fast they progress, so it's not totally cut and dried, even for HD.
Okay, but what about the others? PD, AD, ALS?
Yeah.
Usually not inherited, right?
Usually sporadic, yes. Most cases appear without a clear family link, but for each one, there are known genetic forms. In Parkinson's, you have genes like isonuclein and LRK2 causing dominant forms, and Parkin, DJ1, PNK1 causing recessive forms. For Alzheimer's, mutations in APP, or the presenilin genes, PSEN1, PSEN2, cause rare early-onset inherited forms. And about 10% of ALS is familial, often linked to the C9orf72 gene mutation.
But beyond those direct cause genes, there are risk factor genes, right? The ones that just increase your odds.
Absolutely. And these are probably more relevant for the majority of sporadic cases. They don't guarantee the disease, but they significantly increase your probability. The absolute biggest one is the APOE genotype for Alzheimer's. Having the AC4 version, or allele, dramatically increases risk.
How much?
3 times higher risk, maybe more, with just one copy. And even though less than a quarter of people have it, it's implicated in over half of all AD cases. It's a massive risk factor.
Wow. And for Parkinson's?
For PD, genes like isonuclein, LRK2, tau, and GBA are known risk factors. They load the dice, increase susceptibility.
Okay, so genes play a big role, either directly or as risk factors. What about the environment? What external factors are implicated?
The environmental side is trickier to pin down definitively, but evidence is mounting. Things like infectious agents, environmental toxins, head injuries.
Like TBI, traumatic brain injury.
Yes, TBI is increasingly linked as a potential trigger, maybe priming the brain for later neurodegeneration. We also have specific examples like the toxin MPTP causing a Parkinson's-like syndrome.
I remember reading about that.
And there's growing evidence linking long-term pesticide exposure to PD risk. For ALS, exposure to certain neurotoxic chemicals, like in Gulf War syndrome, has been implicated in some cases.
But connecting all these dots, what's the biggest single risk factor overall?
Unquestionably, it's aging. As we get older, our neurons just aren't as efficient at handling that oxidative metabolism, that energy production process. This leads to more production of reactive compounds, those free radicals, which cause cumulative damage to DNA, lipids, proteins, ultimately contributing to neuronal death. Aging is the backdrop against which all these other factors often play out.
Okay, so given all this complexity, proteins, vulnerability, genes, environment, aging, how do we even begin to approach treatment? What are the main strategies?
Well, we can broadly group them. A lot of the older established therapies fall under neurochemical approaches.
Trying to rebalance brain chemicals.
Well, essentially, yes. They focus on replacing or compensating for damage to specific neurotransmitter systems, like dopaminergic therapy in Parkinson's boosting dopamine, or in Alzheimer's trying to boost acetylcholine.
Managing the chemical imbalance caused by the neuron loss.
Exactly. But the real goal now, the focus of so much research, is neuroprotective and disease-modifying strategies.
Trying to stop the damage itself.
Precisely. Trying to modify the underlying neurodegenerative process. One target here is excitotoxicity.
That glutamate overstimulation thing.
Right. Too much glutamate can kill neurons, especially via NMDA receptors. It's clear in stroke and trauma, maybe less clear, but still relevant in chronic diseases. Drugs like memantine for AD and riluzole for ALS are glutamate antagonists trying to counter this.
And tackling oxidative stress, since aging is such a big factor.
Yes, that's another major push. Research into drugs that boost cellular metabolism, like coenzyme Q10, or general antioxidant strategies to fight off those damaging free radicals.
And the protein problem. Targeting those clumps seems obvious.
It's a huge focus. Discovering those specific culprit proteins opened a massive door. We already mentioned aducanumab targeting A and AD, and there's intense research into antibodies and sophisticated antisense oligonucleotides, ASOs, aimed at clearing or stopping the production of alpha-synuclein, tau, TDP-43, and Huntington. That's a core disease-modifying strategy.
Lastly, the immune system. How does that fit in?
It's increasingly clear the immune system, especially the brain's own immune cells, microglia, play a complex role, sometimes protective, sometimes harmful.
So inflammation in the brain.
Neuroinflammation, yes. Research is trying to figure out exactly how the immune system is involved in AD, PD, ALS, HD. There are no approved immune-targeting therapies specifically for these yet, but lessons learned from treating diseases like MS, multiple sclerosis, are guiding development. Can we modulate the immune response to be helpful, not harmful? That's the question.
Diving deep into specific disorders. 3.1 Parkinson's disease, PD. The dopamine story.
All right, let's really dive into the specifics now, starting with Parkinson's. Most people think of the tremor, but you mentioned there's much more to it.
How much more? Parkinsonism, the clinical syndrome, really has 4 cardinal features. You've got bradykinesia, that's slowness, but also a reduction in movement size.
Like small steps, less facial expression.
Exactly. Then there's muscular rigidity, the stiffness, Third is the famous resting tremor, the shaking that's often worse when the limb isn't doing anything. And fourth, impaired postural balance, leading to gait problems and falls.
And the most common form is idiopathic PD, meaning we don't know the cause.
Precisely.
Yeah.
First described way back in 1817 by James Parkinson as the shaking palsy.
So what's actually happening pathologically inside the brain? What goes wrong?
The key hallmark is the loss of those pigmented dopamine-producing neurons in the substantia nigripars compacta, the SNPC. Along with that neuron loss, you see those characteristic protein clumps, Lewy bodies, inside the surviving cells. And the main component is that misfolded isonuclein protein we talked about.
And the neuron loss is significant by the time symptoms show up.
Hugely significant. Typically 70 to 80% loss of those dopamine neurons before the motor symptoms become obvious. It's quite staggering.
Wow. How does untreated PD usually progress?
Without treatment, it's relentless. Over 5–10 years, patients can become severely rigid, almost immobile akinetic. Death often comes from complications of being immobile, like aspiration pneumonia or blood clots.
But treatment makes a big difference.
A massive difference. Effective treatments have dramatically changed the prognosis. Good functional mobility can often be maintained for many years, and life expectancy is substantially increased, although mortality is still a bit higher than average. Treatment is crucial.
But it's not just about movement, is it? You mentioned non-motor features.
Absolutely critical to recognize those. Parkinson's affects many brain areas, not just the dopamine system. So you get these non-motor features. Some can even show up years before the motor symptoms. Things like anosmia, losing your sense of smell.
Really? Loss of smell?
Yes. Also, a REM behavior disorder, where people physically act out their dreams. And autonomic issues, especially constipation.
And later on.
Later, things like depression, anxiety, and significant cognitive impairment, even dementia, become common. The PD dementia has specific features like attention problems, hallucinations, delusions, issues with planning, and spatial awareness.
It sounds like diagnosis could be tricky, especially with symptoms overlapping other conditions. Can other things mimic Parkinson's?
Definitely. We call it Parkinsonism when something else causes similar symptoms. This could be rare neurodegenerative disorders, certain strokes, or, very importantly, medications that block dopamine receptors.
Which kinds of meds?
Certain older antipsychotics like haloperidol and some anti-nausea drugs like metoclopramide. It's crucial to distinguish this drug-induced Parkinsonism because it usually doesn't respond to standard PD treatments. A good medication history is key. Okay, let's get into the nuts and bolts of the pathophysiology. Understanding this is essential to understanding the treatments. The absolute core issue in PD is that massive dopaminergic deficit.
Not enough dopamine.
Right, because those dopamine-producing neurons in the SNPC that feed the striatum, the caudate and putamen, are dying off. By the time symptoms appear, dopamine levels in the striatum are down by maybe 80% or more.
That's huge. And that insight, the lack of dopamine, led directly to treatment ideas.
Exactly. It led to the logical conclusion. If dopamine is missing, maybe replacing it could restore function.
Before we get to replacing it, can you quickly recap how dopamine works? Synthesis, receptors? That seems fundamental.
Sure. Dopamine is made from tyrosine in the nerve terminals. It's stored, released, taken back up, and broken down by enzymes. Its effects happen when it binds to dopamine receptors on other neurons. These receptors fall into two main families, D1, which includes D1 and D5 subtypes, and D2, D3, D4. They're all GPCRs, G protein-coupled receptors.
Meaning they trigger internal changes, not just open a gate.
Right. Generally, D1 receptors are excitatory, activating pathways like cyclic AMP. D2 receptors are generally inhibitory, reducing activity like adenylyl cyclase. And in the striatum, for Parkinson's, D1 and D2 are the really important ones for movement control.
Okay, now connect this to that basal ganglia model, the modulatory loop. How does that explain the motor symptoms?
Right. This model, though a simplification, is super helpful. Think of the basal ganglia as refining motor commands from the cortex before they go to the spinal cord. The striatum is the main input station, receiving the plan from the cortex via glutamate signals.
And from the striatum, the signals go down two paths, direct and indirect.
Exactly. These two pathways work in opposition to fine-tune movement. First, the direct pathway. Think of it as the go pathway. Neurons go from the striatum directly to the output nuclei, SNP or GPI, which then signal the thalamus, which excites the motor cortex. It uses the inhibitory neurotransmitter GABA. Two inhibitory steps mean the net effect is less inhibition on the thalamus, leading to more excitation of the cortex. It facilitates movement.
Okay, direct pathway, Susan.
What about the indirect?
The indirect pathway, this is the stop or break pathway. It's more complex. Stratum, NASH, GPA, STN, SNPR, GPI output. The first two links are inhibitory, GABA, but the STN sends an excitatory signal, glutamate, to the output nuclei. The net effect here is more inhibition on the thalamus, leading to less excitation of the cortex. It suppresses unwanted movements.
So a delicate balance between go and stop. How does dopamine normally keep this balanced, and what happens in PD?
This is the beauty of the model. Dopamine from the SNPC acts differently on the two pathways. The direct pathway neurons mainly have those excitatory D1 receptors. The indirect pathway neurons mainly have inhibitory D2 receptors. So in a healthy brain, dopamine boosts the direct go pathway via D1 and dampens the indirect stop pathway via D2. It greases the wheels for intended movement.
And in Parkinson's, with no dopamine.
The exact opposite happens. The direct pathway becomes less active, no D1 boost. The indirect pathway becomes overactive, no D2 inhibition. The net result? Way too much inhibitory outflow from the basal ganglia to the thalamus, and therefore much less excitatory drive to the motor cortex.
Which explains the slowness, the rigidity.
Exactly. It explains bradykinesia and rigidity quite well. Now, the model isn't perfect, doesn't fully explain tremor or levodopa-induced dyskinesia, and the real wiring is more complex. But it's still incredibly valuable for understanding the core problem and designing treatments.
It makes total sense, like the brakes are stuck on and the accelerator is weak. So, treatment. The main goal is basically restoring dopamine signaling.
That's the primary focus, yes.
Okay.
Replacing or mimicking dopamine to try and rebalance those pathways. But, and this is crucial, these are symptomatic treatments. They don't slow the underlying neurodegeneration.
Got it. And the cornerstone, the gold standard, is levodopa, or L-DOPA. How does that work? It's magic.
Levodopa is, without doubt, the most effective symptomatic treatment. The problem is, dopamine itself can't cross the blood-brain barrier. Levodopa is a precursor molecule that can get into the brain using an amino acid transporter. Once inside, especially in the remaining dopamine nerve terminals in the striatum, it gets converted into dopamine by an enzyme called AADC. It's this newly made dopamine that provides the therapeutic effect.
But you almost never take levodopa alone, right? It's always with carbidopa. Why the combo?
Absolutely critical point. Levodopa is almost always given with a peripheral AADC inhibitor, like carbidopa or benserazide. These drugs don't easily get into the brain. If you took levodopa alone, most of it, like over 99%, would be converted to dopamine in your gut and bloodstream before reaching the brain. That would make it ineffective and cause nasty side effects like severe nausea and low blood pressure. Carbidopa blocks that peripheral breakdown, so much more levodopa actually gets across the blood-brain barrier and you get far fewer peripheral side effects. Above 75 milligrams of carbidopa a day usually does the trick.
So the combo maximizes brain delivery and minimizes side effects. Smart. What are the effects like and what are the catches with long-term use? You mentioned a flickering switch.
Early on, levodopa can be almost miraculous. Tremor, rigidity, slowness can dramatically improve. Initially, the effects are pretty stable, even though the drug has a short half-life, because the remaining neurons can store and release it smoothly. But as the disease progresses and more neurons die, that storage capacity, that buffering, is lost. That's when the long-term motor complications kick in.
Like wearing off.
Yes, the wearing off phenomenon is very common. The benefit from a dose only lasts maybe 1 to 2 hours, then the symptoms rapidly return. Increasing the dose helps, but often leads to dyskinesias.
Those involuntary movements.
Exactly. Excessive abnormal writhing or jerking movements that can be just as disabling as the Parkinson symptoms. And in later stages, you can get the really frustrating on-off phenomena. Unpredictable swings between being off, stuck, rigid, and on. Mobile, but often with bad dyskinesias. It's incredibly disruptive.
Sounds like a real challenge to manage day to day. Are there newer ways to deliver levodopa to smooth things out?
Yes, that's been a huge focus. There are extended release capsules designed to provide more stable levels. There's even an intestinal gel formulation duopa delivered via a tube directly into the small intestine for continuous infusion, which could dramatically reduce off time for some severe cases.
Wow, directly into the gut.
And for sudden off periods, there's an inhalational levodopa powder for rapid rescue. Subcutaneous delivery methods are also being developed. Lots of innovation aimed at providing more consistent drug levels.
What about the big question? Does levodopa actually slow the disease down? Is it disease modifying?
That's been debated for decades. The big PD-MED trial suggested that starting levodopa early provided a small but lasting benefit in mobility and daily activities compared to starting other drugs first, but it also came with higher rates of dyskinesia. The general consensus now is that levodopa is profoundly effective for symptoms, improves quality of life, increases longevity, but it does not fundamentally alter the progression of the underlying neurodegeneration.
So the pragmatic approach is,
Use it when symptoms become functionally impairing or other treatments aren't cutting it. Focus on symptom control and function.
what about side effects beyond the motor stuff, cognitive and psychiatric issues?
Yes, those are significant, especially with long-term use or higher doses. Hallucinations and confusion are common, particularly in older patients or those with baseline cognitive issues, and it's critical not to treat this psychosis with older, conventional antipsychotics like haloperidol. They block D2 receptors and make Parkinson's much worse.
So what do you use?
Specific atypical antipsychotics like clozapine or quetiapine are preferred. There's also pimavanserin, specifically approved for PD psychosis, which works via serotonin receptors. But all these carry risks, including potential heart rhythm issues, QT prolongation, and a serious FDA black box warning about increased mortality risk in elderly patients with dementia-related psychosis. It's a very careful risk-benefit calculation.
And I've heard about impulse control disorders, ICDs.
Yes, another major concern. Levodopa, and even more so the dopamine agonists we'll discuss, can trigger compulsive behaviors, pathological gambling, hypersexuality, compulsive shopping or eating, really destructive behaviors. Screening is essential. Plus, PD itself carries an increased risk of depression and suicidality, so vigilance is needed there too.
Any critical drug interactions or warnings with levodopa?
Huge ones. Levodopa should never be given with nonspecific MAO inhibitors, older antidepressants, risk of life-threatening hypertensive crisis. Those need to be stopped weeks before starting levodopa. This doesn't apply to the selective MAO-B inhibitors used for PD. Also, abruptly stopping levodopa can trigger neuroleptic malignant syndrome, confusion, severe rigidity, high fever, potentially lethal. Never stop it suddenly.
Okay, levodopa. Powerful but complex. What about dopamine receptor agonists? How are they different?
Dopamine agonists are another mainstay. Their main advantage is a longer duration of action than levodopa.
So better for smoothing out those fluctuations.
Exactly. They help manage wearing off and on-off phenomena.
Yeah.
They were also hoped to maybe delay motor complications by allowing lower levodopa doses, but the evidence for that is mixed. Any neuroprotective effect hasn't really panned out either.
Which ones are commonly used?
The main oral ones are ropinirole and pramipexole. They're primarily D2 class agonists, hitting D2 and D3 receptors. There's also rotigatine, which comes as a transdermal patch.
The patch.
Yes, delivers the drug steadily over 24 hours. Rotigatine hits D2 sites, but also has some D1 activity. Their longer action, 8-24 hours versus levodopa's 6-8, is helpful for fluctuations. Both ropinirole and pramipexole also come in once-daily extended-release forms.
Similar side effects to levodopa or different issues?
Some overlap: hallucinations, confusion, nausea, orthostatic hypotension. Always start low and go slow with titration. But agonists have a couple of distinct, significant side effects.
Sure.
Fatigue and somnolence, sometimes causing sudden, irresistible sleep attacks. Patients must be warned about driving. And critically, agonists have a higher rate of causing those impulse control disorders, ICDs, compared to levodopa. Rigorous screening is vital.
So who gets an agonist versus levodopa first?
It's debated. Many might start an agonist in younger patients, hoping to delay levodopa complications. But again, evidence isn't conclusive. In older patients or those with many other health problems, levodopa-carbidopa is often better tolerated overall.
What about apomorphine? You called it a rescue drug.
Right. Apomorphine is a potent dopamine agonist used specifically as a rescue therapy for acute off episodes. It's given by subcutaneous injection or sublingual film. It acts quickly to turn patients back on. It binds to multiple dopamine receptor subtypes, high D4, moderate D2, D3, D5.
Sounds powerful. Big side effects.
It shares the usual dopaminergic side effects, but it's extremely immunogenic, causes severe nausea. Patients need anti-nausea pre-treatment, usually with trimethylbenzamide, and critically, never combine it with 5-HT3 antagonists like ondansetron, risk of profound hypotension, loss of consciousness, a major contraindication. Other risks include QT prolongation, injection site reactions, and a potential for compulsive use or abuse. The sublingual form can cause mouth sores. So it's reserved for when other strategies fail and requires careful initiation and monitoring.
A potent tool for specific situations. Okay, moving on. COMT inhibitors, how do they help?
Remember how levodopa gets broken down in the periphery? Carbidopa blocks one enzyme, AEDC, but that actually shunts more levodopa towards breakdown by another enzyme, COMT. COMT inhibitors block that enzyme, mostly in the periphery. This increases levodopa's half-life and the amount that reaches the brain. They're essentially levodopa extenders.
Which drugs are these and any key differences?
The main ones are tolcapone, entacapone, and opicapone. They all significantly reduce wearing off. Tolcapone works both centrally and peripherally and lasts longer, but it carries a risk of severe liver toxicity, hepatotoxicity, black box warning. So it's reserved for non-responders and needs liver monitoring. Entacapone works mainly peripherally, has a shorter duration, needs dosing with each levodopa dose, but no liver toxicity risk. Often comes in combo pills with levodopa-carbidopa. Opicapone is newer, once daily, works peripherally, and seems comparable to entacapone in reducing off time. Common side effects for all are nausea, hypotension, vivid dreams, confusion.
Next group, selective MAO-B inhibitors. What's their angle?
MAO-B is the main enzyme breaking down dopamine within the brain, especially in the striatum. So selective MAO-B inhibitors block this breakdown, keeping dopamine around longer.
Which drugs and what are the nuances?
Selegiline, rasagiline, and safinamide. Selegiline and rasagiline are irreversible inhibitors. Safinamide is reversible. They offer modest symptomatic benefit. Importantly, because they are selective for MAO-B, they don't significantly block peripheral MAO-A, so they can be safely used with levodopa and don't cause that dangerous cheese effect interaction with tyramine foods.
Tell me about selegiline.
Selegiline is okay for early mild PD, especially younger patients. Can worsen levodopa side effects in advanced PD. A key point is it's metabolized to amphetamine and methamphetamine, causing potential anxiety, insomnia. Orally disintegrating, and patch forms aim to reduce this.
And rasagiline?
Rasagiline does not have those amphetamine metabolites. Effected as monotherapy early on and reduces wearing off when added to levodopa later. The ADA-GAO study hinted at possible disease modification, but it wasn't definitive. Still an area of interest.
Safinamide?
Safinamide is newer, approved as an add-on for levodopa off periods. It's reversible and might also reduce glutamate release. Needs dose adjustment and liver dysfunction.
Any major drug interaction warnings for these MAO-B inhibitors?
Yes, very important ones. Absolutely contraindicated with meperidine, Demerol, risk of severe reaction. Also contraindicated with tramadol, methadone, dextromethorphan, St. John's wort, cyclobenzaprine. And use caution with antidepressants, SSRIs, tricyclics. Serotonin syndrome is rare but possible. If used together, monitor closely and use low antidepressant doses.
What about the older muscarinic receptor antagonists or anticholinergics? Do they still have a role?
Drugs like trihexyphenidyl and benztropine, they have modest effects, mainly on tremor and rigidity. Might block acetylcholine's action in the striatum. Used sometimes early on or as adjuncts. But their anticholinergic side effects, sedation, confusion, dry mouth, constipation, are often limiting, especially in the elderly. They can significantly worsen cognition, not usually a first choice.
And amantadine, the antiviral that also helps Parkinson's.
Yes, amantadine is interesting. Its mechanism isn't fully clear, seems to affect dopamine release, has anticholinergic effects, and blocks NMDA glutamate receptors. Useful for mild early symptoms, and particularly helpful as an adjunct later on for managing levodopa-induced dyskinesias. Generally well tolerated, side effects are usually mild, dizziness, sleep issues, nausea.
And the newest mechanism is istrophyline, targeting adenosine receptors.
Right, istrophyline is an adenosine A2A receptor antagonist. These A2A receptors hang out with D2 dopamine receptors in the striatum. Activating A2A inhibits D2 signaling. So by blocking A2A, istrophyline takes the brakes off D2 signaling, indirectly boosting dopamine's effect. It's approved as an add-on for off periods. Generally well tolerated. Small studies hint it might help some non-motor symptoms too.
Looking ahead, what are the big hopes? The disease-modifying targets for PD?
The ultimate goal is to slow or stop the progression. Key targets right now include alpha-synuclein, trying to clear these aggregates with monoclonal antibodies in phase 2 trials, LRRK2, inhibiting its overactive kinase enzyme implicated in genetic and sporadic PD inhibitors in trials, GBA, boosting the activity of this enzyme, mutations are a risk factor, or reducing its substrate, compounds in trials. These are the cutting-edge efforts to really change the disease course.
So wrapping up PD treatment, for someone wanting that elite perspective, how is it tailored?
It's highly individualized. Early on, exercise and lifestyle are key. Mild symptoms might get an MAO-B inhibitor, amantadine, or maybe an anticholinergic if young. Eventually, most need potent dopaminergic therapy, levodopa, or an agonist.
Agonist first for younger, levodopa for older comorbid.
That's often the thinking, yeah. Agonists maybe delay motor complications, though evidence is iffy. But levodopa is often better tolerated overall, especially in the elderly. It's a shared decision, balancing efficacy, side effects, age, and patient priorities. 3.2 Alzheimer's disease, AD. The memory thief.
Okay, let's pivot to Alzheimer's disease, the memory thief. Where does AD primarily attack in the brain, and what are those key pathological signs?
The regions hit hardest in AD are absolutely crucial for memory. The medial temporal lobe, especially the entorhinal cortex and the hippocampus. These are the brain's memory processing centers. Pathologically, the hallmarks are those two protein accumulations we discussed. Amyloid plaque, forming amyloid plaques outside cells, and the protein tau, forming neurofibrillary tangles inside cells. Both contribute to the damage.
And how does it typically progress, from subtle signs to severe dementia?
It usually unfolds over years, often starting with a long, silent preclinical stage. Amyloid and tau are building up, but no symptoms yet. Then comes mild cognitive impairment, MCI. Noticeable memory issues, repeating questions, losing things, but the person can still function reasonably well day to day. Finally, it progresses to the dementia stage, with widespread loss of functional abilities impacting daily life. It's invariably fatal, usually within 6-12 years from symptom onset, often due to complications like pneumonia.
How has diagnosis changed? It's not just about observing symptoms anymore, right? Biomarkers.
Exactly. Diagnosis has been revolutionized by biomarkers. We can now measure air and tau changes in cerebrospinal fluid, CSF, or even plasma, blood tests. And imaging biomarkers are huge. Structural MRI can show hippocampal atrophy. FDG-PET scans show reduced brain activity. And crucially, specific PE scans can now visualize amyloid deposition or tau deposition directly in the living brain.
Are there approved agents for those protein PE scans?
Yes. For amyloid PT, we have florbetapir, flumetamol, and clorbutabin. For tau peak, there's flortazapir. This allows for a biological diagnosis using the ATN framework amyloid tau neurodegeneration status.
Under this research framework, evidence of amyloid pathology is now required for a biological diagnosis of AD. It's a major shift towards biology.
Given that protein focus, let's talk genetics. What causes the rare inherited forms, and what are the big risk factors for the common type? The rare early-onset autosomal dominant AD is caused by mutations in just 3 genes: APP, the precursor protein for AGER, PSEN1, or PSEN2, which make up the core of G secretase, an enzyme that cuts APP to produce A. All 3 directly impact A traduction. This is the strongest evidence for the amyloid hypothesis that A accumulation drives the disease.
So early onset AD points squarely at amyloid. What about the common late onset form? What loads the genetic dice there?
For late onset AD, the biggest genetic risk factor by far is the APOE gene, specifically the A4 allele.
We mentioned this earlier. Having the AP4 version significantly boosts risk.
Massively. 1 copy triples your risk or more. And while less than 25% of people have it, it's linked to over 50% of AD cases. It's a huge susceptibility factor, though not a guarantee.
So plaques and tangles are the signs. How do they actually cause the damage? What's the cascade?
The current thinking is that amyloid plaques start depositing first, maybe decades before symptoms. Tau tangles seem to build up later and correlate better with cognitive decline severity. Why amyloid builds up isn't totally clear. In late onset AD, maybe problems with clearing it, whereas in early onset, it's overproduction.
And is it the big plaques causing the most harm?
Increasingly, the evidence points to soluble oligomers, smaller clumps being more toxic, directly interfering with synapses. For tau, abnormal modifications like phosphorylation make it prone to aggregate into tangles inside the neurons. Both agalon and tau likely cause damage through multiple mechanisms, impairing synapses, excitotoxicity, oxidative stress, neuroinflammation. It's a complex mess.
What about the brain chemistry, the cholinergic hypothesis?
That was an early important observation. AD patients have a significant deficit in the neurotransmitter acetylcholine, ACH, due to loss of the neurons that produce it. Blocking AC causes confusion similar to AD, supporting the idea that this deficit was key to symptoms that led to the first drugs. But AD is much more complex. Other systems like glutamate and serotonin are involved, and the target neurons in the cortex and hippocampus are also dying. Boosting HE helps symptoms, but it's not the whole story.
So how do we treat AD now, given this complexity? What's approved?
Currently, 3 main classes: cholinesterase inhibitors, memantine, and the newer anti-AA antibodies, often used in combination.
Let's break those down. Cholinesterase inhibitors first. How do they work?
They were the mainstay for decades. They block the enzyme cholinesterase, which breaks down acetylcholine. This increases available AHE, compensating for the deficit. Drugs are donepezil, rivastigmine, galantamine, used for mild to moderate AD, sometimes other dementias too.
What kind of benefit do they provide?
It's symptomatic and modest. Usually a delay in progression for maybe 6-12 months, not a dramatic improvement. Decline continues afterwards, generally well tolerated. Main side effects are GI issues, muscle cramps, weird dreams, caution with slow heart rate. Rivastigmine also hits another enzyme, Bushi, and comes with a patch, which reduces GI side effects.
Okay, then memantine, targeting glutamate.
Memantine works differently. It's an uncompetitive antagonist of the NMDA glutamate receptor. It selectively blocks the excessive pathological activation linked to excitotoxicity, while allowing normal activation needed for learning, like a filter for glutamate signals.
When is it used?
Indicated for moderate to severe AD. Little evidence it helps much earlier. Like the cholinesterase inhibitors, it temporarily slows decline. Side effects usually mild, like headache or dizziness. Needs dose adjustment in kidney problems.
And the big newcomer, amyloid immunotherapy, like aducanumab. Huge deal, right? Even with the controversy.
Absolutely a landmark moment. Aducanumab was the first disease-modifying therapy approved, a monoclonal antibody designed to clear amyloid plaques. It got accelerated approval based on the biomarker, plaque reduction, not proven clinical benefit, which caused a lot of debate. A follow-up trial is required to confirm clinical benefit.
Who is it for and how is it given?
Indicated for patients with MCI or mild dementia due to AD. The idea is it works best earlier, before too much irreversible damage occurs. Patients need confirmation of amyloid pathology via PT scan or CSF. It's given as a monthly IV infusion. Requires regular MRI safety scans before and during treatment.
Why the MRIs? What's the risk?
To monitor for ARIA's amyloid-related imaging abnormalities, these are common, seen in almost half of trial patients. Can be brain swelling, ARAE, or microhemorrhages, ARE-DH, often asymptomatic and reversible if treatment stops, but can cause headache, dizziness, nausea, sometimes serious issues. Monitoring is crucial.
Beyond the cognitive stuff, managing behavioral and psychiatric symptoms, BPSD, must be a huge challenge.
Immense challenge. Irritability, agitation, paranoia, delusions, wandering, anxiety, depression, very common, especially mid-stage. First line is always non-pharmacological approaches, adjusting the environment, routines, activities, communication strategies.
And if that's not enough, drugs.
Yes, but cautiously. Cholinesterase inhibitors and memantine might help a bit, but not usually with severe agitation. The SSRI citalopram showed some efficacy for agitation. Atypical antipsychotics, risperidone, olanzapine, etc., can work better for agitation psychosis, but
The big downsides.
big downsides. Risk of Parkinsonism, sedation, falls. And that critical FDA black box warning about increased risk of stroke and death in elderly dementia patients. A very serious trade-off. Benzodiazepines are generally avoided long-term due to cognitive worsening and fall risk. Older antipsychotics like haloperidol only for acute aggression due to side effects.
So putting it all together for AD, typical treatment path.
Early stage, likely start a cholinesterase inhibitor. Crucial counseling. Goal is temporary slowing of decline, not recovery. If amyloid positive, consider amyloid immunotherapy like aducanumab, discussing risks benefits thoroughly. As it progresses to moderate severe, add memantine. For behavioral issues, try non-drug methods first. Then maybe an SSRI, or, if severe and risks are weighed, a low-dose atypical antipsychotic. And absolutely critical, eliminate drugs that worsen cognition, anticholinergics, benzos, heavy sedatives. Clean up the medication list. 3.3 Huntington's disease, HD. The dance of chorea.
All right, let's shift gears to Huntington's disease. Known for the chorea, the dance-like movements, but it's inherited, right?
Yes, HD is fundamentally different because it's an autosomal dominant inherited disorder. If you inherit the gene, you get the disease. It typically starts gradually in midlife with both motor incoordination and cognitive decline.
What are the key symptoms?
The hallmark movement is chorea, those brief, jerky, unpredictable movements. But psychiatric symptoms are also very common, sometimes appearing first. Early on, maybe just subtle clumsiness or eye movement issues. Later, the chorea worsens, plus dysarthria, speech problems, dysphagia, swallowing problems, and poor balance leading to falls.
What about the cognitive and psychiatric side?
Cognitively, it's often slowed thinking, trouble organizing tasks. Memory is affected, but differently than AD, they usually retain personal memories. A key tragic feature is often a lack of insight into their own illness. Behaviorally, obsessive-compulsive behaviors and depression are common. Psychosis can occur, and sadly, there's a very high risk of suicidality.
Prognosis.
It's invariably fatal. Over 15-30 years, it leads to total disability requiring full-time care. Death is usually from complications of immobility.
The genetics are stark. Autosomal dominant, near 100% penetrance. What's the specific gene defect?
It's an expanded CAG trinucleotide repeat on chromosome 4. Normal people have maybe 934 CAG repeats. HT patients have 40 to over 100.
And more repeats means?
Means earlier onset, generally. There's a strong inverse correlation. More repeats, younger onset, often more severe. We still don't know exactly how this expansion causes the disease. The repeat is in the HTT gene, which codes for the Huntington protein. The CAG repeat codes for the amino acid glutamine, so the mutant protein has this abnormally long polyglutamine tract.
So this faulty Huntington protein causes the brain damage. Where does the damage happen and how does it relate to chorea?
The most prominent neuronal loss is in the striatum, putamen. Specifically, the medium spiny neurons there are hit hard, while other cells are relatively spared. This leads to a big drop in the inhibitory neurotransmitter GABA in the striatum. There's also significant neuron loss in the cortex. The chorea seems linked to which pathway gets hit first. In adult-onset HD, the neurons of the indirect pathway, the brake, seem to degenerate earlier than the direct pathway neurons.
So less braking leads to involuntary movements.
Exactly. Lifting the inhibition increases excitatory drive to the cortex, causing chorea. Interestingly, in juvenile-onset HD, where rigidity is often more common, both pathways might be affected more equally.
Since there's no cure, what's the goal of treatment?
Purely symptom management. No current drugs slow the disease progression. The focus is on improving quality of life by managing the motor and psychiatric symptoms.
How do you treat the chorea?
The main drug is tetrabenazine. It inhibits VMAT2, a transporter that packages neurotransmitters like dopamine into vesicles. This depletes dopamine presynaptically, reducing the drive for chorea. An older related drug is reserpine, but it's irreversible and has longer-lasting side effects.
Is tetrabenazine tricky to use?
It can cause hypotension, sedation, Parkinsonism, and, importantly, depression with suicidality. Its shorter duration helps manage side effects compared to reserpine. Dosing starts low. It's metabolized by CYP2D6, so interactions with inhibitors like some antidepressants are a concern, contraindicated with MAOIs.
What about deutetrabenazine, a newer version?
Yes, it's deuterated tetrabenazine. The deuterium makes it metabolize more slowly, allowing for potentially less frequent dosing and maybe a lower risk of depression, similar effectiveness otherwise.
How are the psychiatric and behavioral symptoms managed? That sounds like a huge part of care.
Absolute critical. Depression responds to standard antidepressants, SSRIs, SNRIs. Avoid ones with anticholinergic effects, as they can worsen chorea. Psychosis or paranoia might need antipsychotics, but use the lowest possible dose due to cognitive and motor side effects. Clozapine or quetiapine might be better for rigid HD. Anxiety can be managed judiciously with benzodiazepines short-term. Rigidity in juvenile cases is tough. Maybe try dopamine agonists. Myoclonus or seizures respond to anticonvulsants like clonazepam or valproate.
And cognitive enhancers.
Unfortunately, cholinesterase inhibitors haven't shown benefit for HD cognitive decline.
Any hope on the horizon, especially genetic therapies?
Huge hope there. Given the clear single-gene cause, HD is a prime target. Antisense oligonucleotides, ASOs, are in development. These are designed to bind to the Huntington RNA and promote its degradation, reducing the production of the toxic protein. Early trials showed promise, reducing Huntington levels in CSF.
So directly targeting the faulty gene product?
Exactly. Other approaches like RNA interference are also being explored. This is where the real hope lies for fundamentally changing the disease. 3.4 Amyotrophic Lateral Sclerosis, ALS, the motor neuron disease.
Finally, let's turn to ALS, Amyotrophic Lateral Sclerosis, Lou Gehrig's disease. What defines this condition?
ALS is a devastating attack specifically on motor neurons, both the lower ones in the spinal cord and brainstem, and the upper ones in the brain that control them. This leads to rapidly progressive weakness, muscle wasting, atrophy, twitching, fasciculations, stiffness, spasticity, trouble speaking, dysarthria, trouble swallowing, dysphagia, and eventually respiratory failure.
Is there an overlap with other conditions?
Yes, increasingly we recognize an overlap with frontotemporal dementia, FTD. Many ALS patients show cognitive and behavioral changes, and there are shared genetic and pathological features.
Prognosis.
Usually rapidly progressive and fatal. Most patients die from respiratory failure or pneumonia within 2 to 3 years, though there's variability and some survive much longer.
What about the causes? Genetics, pathophysiology.
About 10% of cases are familial, FALS, mostly autosomal dominant. The most common gene mutation by far is in C9orf72, a repeat expansion responsible for up to 40% of FALS and even some sporadic cases. Other FALS genes include SOD1 and TARDBP, which makes the TDP43 protein, and FUS-TLS. TDP43 and FUS are involved in RNA processing, suggesting that's a key pathway gone wrong. Most cases, 90%, are sporadic. The cause is often unclear, though some might be new mutations in those same genes. The underlying mechanisms likely involve abnormal RNA processing, glutamate excitotoxicity, oxidative stress, mitochondrial problems, a complex mix.
What treatments are available? Have there been breakthroughs?
It's been tough, but there are 2 FDA-approved drugs that offer some benefit. The first breakthrough was Riluzole.
How does riluzole work?
Its actions are complex. It seems to inhibit glutamate release, block glutamate receptors and MDA and kainate types, and inhibit sodium channels, basically dampening down motor neuron hyperexcitability. It's taken orally, generally tolerated, maybe some nausea, diarrhea. Rare liver injury risk needs monitoring.
What effect does it have?
Meta-analyses show it extends survival, on average, by about 2 to 3 months. It sounds modest, but for a relentlessly progressive disease with nothing else, it was a huge therapeutic milestone when approved in 1995.
And the newer drug, edaravone.
Approved in 2017. Edaravone is a small molecule with free radical scavenging properties and antioxidant, believed to reduce oxidative stress on motor neurons. The clinical trial data was a bit complex, but a trial in early-stage ALS patients showed a small reduction in functional decline over 6 months. It's given intravenously on a cyclical, quite intensive schedule. Contains bisulfite, so hypersensitivity reactions are a caution. Side effects include bruising, gait issues, headache.
What about managing symptoms like spasticity? That must be awful.
Spasticity, the stiffness and resistance to movement, is a major issue, causing pain and hindering function. But it is treatable symptomatically. The best agent is usually baclofen, a GABAB agonist. It works in the spinal cord to reduce hyperactive reflexes. Can be given orally, sometimes at high doses, or even intrathecally via a pump for severe cases, though that carries risks. Tizanidine, an alpha-2 agonist, is another option, also working centrally to reduce spasticity. Drowsiness can limit its dose. Benzodiazepines can help but risk worsening respiratory function, which is already compromised in ALS.
Is dantrolene used?
Absolutely not in ALS. Dantrolene works directly on the muscle to weaken contraction by affecting calcium release. While used for spasticity and stroke spinal injury, in ALS it would exacerbate the underlying muscle weakness. Big contraindication. Outro.
Wow. Okay, that was a true deep dive. We've really navigated the incredibly complex world of neurodegenerative disorders. We covered the common ground protein issues, selective vulnerability, and then got into the specifics of Parkinson's, Alzheimer's, Huntington's, and ALS. The science, the treatments.
Yeah, it's a lot to take in.
But hopefully you, our listener, now have that deeper understanding, that ability to connect the dots and see the patterns, almost like the elite professionals working in this field every day.
And if we connect it all to the big picture, it's clear, isn't it? We've made huge strides in understanding these diseases, managing symptoms, really improving lives compared to decades ago. But that ultimate goal, preventing them, curing them, that's still the frontier. That's where the intense research continues. Which maybe leaves us with a thought for you to mull over. What's next? What breakthrough, maybe in genetics, neuroimaging, maybe even AI, might unlock that next fundamental piece of the puzzle for these devastating conditions? And thinking about your own role as someone who's now much more informed, how can you contribute? Maybe through advocacy, supporting research, just understanding. What's your part in facing this challenge?
That's a powerful question to consider. Thank you for joining us on this comprehensive exploration. Until next time, keep digging, keep learning, and keep up your own deep dive.